Hello, I'm Dr. Jack Hahn, and I'm going to present three different phases associated with implant dentistry. The first phase is going to be flap designs in the aesthetic zone and anterior tooth single tooth replacements. The second portion of this presentation is going to deal with flapless surgery indications with illustrating of some cases. And the third portion is going to be dealing with the advantages of custom abutments. So first we're going to start with flap design incisions in the anterior and the aesthetic zone. So it's very important that in delivering implant dentistry to our patients, they expect the best and they expect optimum aesthetics. And every patient has a high smile line. You may think that they're not going to show the gum, but every patient, the minute you give them a mirror, that's what they're going to do. They're going to raise their lip and you're going to see the gum. So we look at how do we preserve this? And another idea is we can help prevent doing connective tissue grafts if we design our flaps properly. So you can see here is a site where we're going to place a single implant to replace a central incisor. So we're going to design the flaps so we come around from this area in here. We're going to come around the lingual. Now the lingual side of the crest is keratinized tissue. And that's the tissue that we want to have on the facial surface when we going to place the implant and we're going to place the abutment. So the more of the keratinized tissue on the facial, and using the masticatory mucosa, the better it's going to look, and we're going to keep the restoration in line with the adjacent tooth. So here you can see again this incision where we're coming around from the mesial so we don't disturb the papilla here, and we come around the lingual, taking this lingual palatal part of the tissue and bringing it up forward and placing the implant. This picture here is actually at second stage uncovering, where we're actually doing the same thing and placing this tissue here and placing a healing abutment. Then after it heals, we can do an implant level transfer, and then you see the custom abutment. This is titanium, and then a ceramic Bruxer crown, and then you can see the follow-up x-ray. Now this area was previously grafted, and you can see some of the residual graft material that's actually, you can see though, it's supporting the papilla very nicely. So what we look at is gingival harmony, that the adjacent tooth, or the implant restoration, the gum line is in the same plane as the adjacent teeth. In other words, if we design our flap right, the idea is to have the tissue at the same level, not up in here. If you use a tissue punch, there's a danger that the tissue is going to be up here. And even though you have a crown that the color is good, the patient's not going to like it. The other thing that preserves the tissue is our implant placement. We want to place it closer to the palatal bone, which is a more dense bone, and we want to avoid placing it too facial. We want to avoid penetration of the subnasal fossa and place the implant even or slightly above the crest if we have enough soft tissue. So basically, the bone sets the tone, but the tissue is the issue when we're looking at implant aesthetics in the anterior region. So this is just an illustration of ideal implant placement is further palatal against the palatal bone and staying away from being close to the facial. So the most common beginning error is placing the implant too far labial. And this is very difficult or impossible to correct. And the error is best avoided if you enter into the palatal side of the crest. So here's an illustration or demonstration on a model where we're making a buccal lingual imaginary line and then a mesial distal line, creating a target in the center. And we can go 1 to 2 millimeters parallel to the center portion of the target and make our penetration. If you're making a surgical guide, And you can do this on the model, and the next few slides will illustrate that. So we have ideal placement away from the facial bone. If it's too far facial, then you have a chance to get an avascular necrosis, which means that the tissue and the bone is going to resorb and the patient's going to show metal. There'll be threads showing. So placing it more to the palate, you're going to avoid that problem. So here's an illustration of the drill, the 2mm twist drill entering on the palatal side of the crest. Just about 1 millimeter to 2 millimeters. And then again placing the implant to the palatal bone. And you can see that there's more facial bone, and this bone here is more dense than this bone in the facial. It's thin and doesn't have good blood supply, so the more bone that we can have between the implant and the facial cortical bone, the better it is. Now, why does this work in a natural tooth? Well, the natural tooth has a periodontal ligament, and there's blood supply to the thin cortical bone. If we look at cross-section, we see that there's more bone on the palatal side where we have an opportunity to move that drill, as shown in this picture here, where we can go to the palate side of the crest. Now, what is the consequence of too far labial? Well, this patient had an avascular necrosis. There was threads showing and the tissue was receding, but the implant was integrated. And there really wasn't any more bone loss where it created pocket formation. So basically, we have to prepare directly on the implant, smooth the threads, create a finish line as if you were working on a tooth, and creating a margin and taking a direct impression. And then the laboratory has to be creative in making a ceramic metal crown here with a porcelain, pink porcelain gingiva. So here's an example how you can do this on a model. Again, drawing the crossbow, mesial distal, buccal lingual, and then entering on the palatal side of the crossbow. You can take a drill guide. There are many that are available, these drilling sleeves. And then you have a guide where you can put this in the patient, and then you can enter through the soft tissue into the bone. And then when you make your flap design, you can see where you entered. And if you're not happy, you can make the adjustment. So you can take a bone caliper, anesthetize the patient, and then this bone caliper has a needle on the buccal, a needle on the lingual, and you put them together, and it tells you how wide that bone is. Ideally, for a 3.5 millimeter diameter implant, we would like to have 5.5 to 6 millimeters of buccal lingual bone. So now you can see on the model that we're making the incision on the palatal side of the crest. Coming around to release it so we can bring the tissue back and expose the lingual side of the crest of the bone. Now here, instead of going through and showing the U-shaped or the V-shaped design, here we're showing where we want to expose more of the bone. So we're making, again, on the palatal side of the crest, we're going to come around the mesial of the adjacent tooth. And if we want to make a more accessible flap, then we want to make our oblique incision between the cervical and the papilla, and the peak of the papilla, in between, so that we don't make a vertical here because we could cause recession, and if we make a vertical at the tip of the papilla, we could blunt the papilla and lose that, and then the patient's going to have a dark space. So then we can have a non-tension closure. So now you can see where the bone is, your buccal lingual width, and you want to be parallel to these adjacent roots when you enter into it. Now, if you use that little guide that you made on the model, you went in and it about maybe 4 or 5 millimeters, you could see the mark. If you're not happy, that's the time you can make an adjustment. You want to root plane the adjacent teeth so we don't get any toxins, any deposit that's on the teeth into the osteotomy to help prevent a post-operative infection. So there you can see the 2mm twist drill is parallel to the adjacent teeth. So you can see the line. Generally, we'd like to keep this in line with the incisal edge of the adjacent teeth. So no need to reflect the soft tissue if you perforate it. So you want to change the direction of the twist drill. So if you perforate it into the subnasal fossa, you want to back out and redirect it to the palatal. So after you prepare the implant site, ready for the implant, then you can take some bone material, mix it with saline. Now you don't need to flap. I've only done this for demonstration. You can see where it was perforated with the drill, with the twist drill. So you can take and hydrate with saline, whatever bone material that you like to use, get it into a slurry mix, not compacted, but very loose, and put it in the osteotomy. And as you place the implant, it forces it through the opening and seals it because you have the periosteum and the tissue on the bone. So there again, you can see ideal placement, closer to the palatal bone and more bone to the fascial. So then we can make our closure, our interrupted. We want to do our obliques first and then the horizontal next. And then if we go to uncover, then we can come in with this U-shaped here, or we can come back to this and here. It really doesn't make a lot of difference. But the main thing is you're keeping this tissue up to there. So when you put on a healing abutment at that point, you're not going to get closure, complete closure. So we want to keep that tissue to the fascial. Now, there is going to be a space in here. Now what happens to that space is the buccal tissue, the labial tissue, grows and meets the lingual tissue as that grows. So they grow to each other, and that creates papilla. So you see what the healing abutment. Now after healing, implant prosthetics is just unscrewing the healing abutment, placing an impression coping, taking an impression, taking a bite, and sending it to this laboratory. So here again you see an illustration of the flap design. It's more to the palatal side of the crust. So we're taking again this mascatory keratinized mucosa and placing it more to the labial, and we have access, and we can see we keep the implant more to the palatal bone, which we discussed is more dense and away from the fascial bone. Place a healing abutment. Since we have good primary stability, because we achieve this in anterior bone is generally type 2 bone between premolar and premolar. So we place a healing abutment, and after sufficient time, generally 3 to 4 months, we can remove that, take an implant level transfer. The laboratory will create a custom ceramic zirconia abutment and a ceramic zirconia crown, optimizing the aesthetics, and you've optimized the soft tissue. And again, you can see the soft tissue is in harmony with the adjacent teeth. And I think the laboratory has done a very good job in matching the shade because, as we know, single tooth replacements in the anterior, in the aesthetic zone, is very difficult to match the shade. So here we see either 5 or 6 implants were placed, I believe 6, for a Bruxer hybrid zirconia prosthesis, and this is at the uncovering stage. So we see that the implants, the trajectory came to the fascial, and we don't want to use a tissue punch because then the buccal margin and the labial margins are going to be in unsupported, non-keratinized tissue. So in order to do that, again, we're going to make our incision to the palatal side of the crest and bringing the keratinized tissue to the labial, as you can see here. So this prevents from doing or helps reduce the need for connective tissue graft. So it's simpler. It's very simple. And, you know, the tissue is like water. How it heals, it seeks its own level. So here it'll be nice and blended. And maybe the next time we meet, we'll be able to show you this case that's finished. So the next case, illustrating a custom abutment and keeping the gingival margin in harmony. We see a patient that was in a bicycle accident and fractured number 8 and 9. They were unsalvageable. And so they removed, 2 implants were placed. And here you can see at the impression appointment, again, we can see we tried to preserve the soft tissue, keeping the implants away from the facial bone. The implant restoration, you can see that custom abutments, zirconia abutments, were performed by this laboratory, delivering also the 2 Bruxer crowns on 8 and 9. And we have a patient that's very happy with a very nice result. You can see how nice the papilla is formed. So these were immediate replacement implants. And thank you for watching.